Speaker is Dr. Poornima Sheba Abraham from Girdhara Institute. She'll be speaking on Sutured SFIOLs. She is a very gifted cataract surgeon. Since the last 12-15 years, she had been doing umpteen number of cataract surgeries in the hospital.
I wish everyone a very good morning and a great academic feast. Thank you, Dr. Lakshmi. I'll be vouching for sutured scleral fixated IOLs in my talk. So we know when any type of secondary IOL is indicated, but then you should also know when to avoid using them. That is very important as well. We know that a very thorough clinical assessment is essential before planning any of these procedures. Especially a very good biometry is required. Any of the newer generation formulas hold, good. They give excellent results. What to keep in mind is a myopic shift is seen if sutured IOLs are positioned beyond 2 mm from the limbus. Now, if you're taken by surprise and you plan to place an SFIOL in the primary sitting itself, you could use this rule of nines, to deduct from the intra-bag target, which you have already, which you have in your hand. Once you decide to put an SFIOL, it's time to, make a decision as to when to do the surgery and what approach to take. So an anterior approach would be an easy way, and it would be most convenient in most of the settings. However, a posterior approach along with vitrectomy is said to have less lens dislocation incidences. And whether to do it at the primary sitting itself, although it has certain advantages, always planning properly and delaying the secondary procedure would be favorable in the long term. What lenses do we have? So we have the rigid PMMA lenses as well as foldable lenses with eyelets. There are various modifications of the procedures wherein you can use regular lenses as well. The sutures that we generally advise is the 90 polypropylene or Prolene, which has its advantages versus the 10-0 Prolene, which used to be used earlier. And the Gore-Tex or PTFE suture, which is now gaining popularity for its durability, is also advised. Now, various techniques have come about from when Malbran introduced this sutured concept. But then the choice of surgery is based on the surgeon. If you're comfortable with one type of procedure, stick to it. It'll be at par with any other. Now, this video here demonstrates a 4-point fixation technique. You can see the cornea has been marked prior. This helps to, create the flaps in the right place so that IOL centration is best with that. We've done a conjunctival peritomy, partial thickness scleral flaps are being fashioned here. They measure about 3 mm. Since we'll be using a PMMA lens here, a rigid lens, we have to make a corneoscleral wound. Now, the sclerotomy is an ab externotype, that is, you're going in from the outside. The suture uses a 90 Prolene suture with straight needles. It is docked into a 26 gauge needle by the railroad technique, and it is externalized through the corneoscleral tunnel. Now, we have this lens with the eyelet on the haptic, which is a rigid haptic. Now, when we pass the needle, just make sure to be gentle, otherwise the haptic may break. We make another sclerotomy about 1.5 mm away from the first. And then again, this railroad technique is employed to bring the suture out back under the scleral flap. So what to note here is that the sclerotomies have to be both radially arranged from the limbus, and about the sclerotomies are about 2 mm, 1.5 to 2 mm from the limbus. Now this procedure, the process is repeated on the other side as well. Railroading being done here. So for want of time, I'm just skipping that part. The fourth sclerotomy being made and the needle being passed. So once the needle, both the sutures have been brought out, the IOL is gently slid into the AC and then introduced into the sulcus. Gently dialed into the sulcus behind the iris. The IOL can be centered by just adjusting the sutures, and then the sutures are tied and the knots buried under the scleral flap. Conjunctiva can be closed in any fashion. Just what to note is that the aim should be to place in the sulcus, and the haptic should be about 180 degrees apart. Just keep in mind that a tilt of more than 5 to 15 degrees can cause gross aberrations. So there are various other modifications which have come by, and which are very popular nowadays, is the 2-point Sermon's knotless technique, where multiple zigzag partial thickness bites, scleral bites are taken. The suture follows a zigzag path, and then there is no knot. The suture is just cut flush to the sclera. Or the 4-point fixation with knot burial by Beccara, where he buries a knot by just rotating it into the globe. And all these procedures have good outcomes. There's also this double flange fixation of single piece foldable lenses, which have been described. You could also avoid a peritomy by using a Hoffman's pouch, especially in scarred eyes. So previous literature has suggested that IOL dislocation due to suture breakage was as high as 1.2 to about 40%, but more recent studies with significant long-term follow-ups, you can see the arrow here, practically no suture breakage recorded. And more so, the more common complication would be knot erosion through the sclera, so which can be managed by avoiding knots, following knotless suture techniques. So the rest of all the complications mentioned would pan the entire spectrum of secondary IOLs. So I would like to stress that it is quite a safe and effective option, and can be planned in any setting. It doesn't need any fancy equipment, and it just needs a bit of practice to overcome the fear of implanting a sutured SFIOL. These are some of my references. Thank you.
Yes, practice makes the technique perfect. Thank you, Dr. Poornima, for that wonderful